Şimdi konuşmalarını yapmak üzere bariatrik hastada gastroözofajal reflü en uygun yöntem nedir? Sayın Philippe TOPART. Buyurun.
Herkese günaydın ve tekrar misafirperverliğiniz için teşekkür ediyorum. Ve Can Karaca'nın bahsettiğini toplumda bir hastada kanayan bir marjinal ülser olduğunu öğrendim. Çok kötü ama bu risk gerçekten olur. So I was asked to present to you the best option for patients with gastroesophageal reflux and before bariatric surgery. And of course, I could have stopped here because the answer is Roux-en-Y gastric bypass, but the picture is probably not so simple, and I tried to go a bit deeper into it. Gastroesophageal reflux and obesity are a very frequent association, at least regarding the symptoms, which are very subjective, and as you can see in large series of at least 100,000 patients before undergoing bariatric surgery, there is roughly 30% of patients reporting gastroesophageal reflux. However, half of this population may be normal on objective testing, pH recording, manometry, and so forth. At least when endoscopy is performed, erosive esophagitis and ANTALYA can show up in about 1/3 of the cases. In fact, all the bariatric procedures are known to improve gastroesophageal reflux, but Roux-en-Y gastric bypass remains the best. And Sudan and Sword in 2017 reporting a significant greater effect of Roux-en-Y gastric bypass over biliopancreatic diversion, gastric bending, and sleeve gastrectomy, which was the least effective regarding reflux. Again, a significant improvement in gastroesophageal reflux score after Roux-en-Y gastric bypass. And as you can see on the left side, you can see the difference between the sleeve and gastric bypass regarding the percentage of remission of gastroesophageal reflux after surgery. And if you compare this author, you can see that we have 74% here for the gastric bypass and just 40% for the sleeve gastrectomy. And again, the same differences can be seen for the authors who compared the two operations. And again, the score changes between the different procedures, with the pre-op of 2.8% for the Roux-en-Y gastric bypass, roughly the same for gastric bending and sleeve gastrectomy, and you can see that it goes further down for the gastric bypass compared with the other procedures. In addition to the procedure itself, the weight loss improves gastroesophageal reflux, And Palati in Sword in 2014 showed that there was a direct correlation between the percentage of excess weight loss and the improvement of the gastroesophageal reflux score. So the higher weight loss, the greater improvement in gastroesophageal reflux score. But for a given weight loss, there is still a significant advantage for the Roux gastric bypass over sleeve gastrectomy or gastric bending. Roux gastric bypass is also known to improve Barrett's esophagus when present, and in obesity surgery in 2019, meta-analysis of Roux gastric bypasses strongly associated this operation with the regression of Barrett's esophagus. However, population was small, as you can see, because Barrett's esophagus is not so frequent. Despite this positive effect of the Roux gastric bypass, just like de novo gastroesophageal reflux can occur, as you can see, it may occur 4 times more frequently after sleeve gastrectomy than after Roux gastric bypass. But even in patients who do not report reflux before the operation, you can have reflux after Roux gastric bypass, as you know. And even when gastroesophageal reflux is improved by the Roux gastric bypass, it can worsen over time after the surgery. And in this case, it has been shown that after Roux gastric bypass, in patients who had a reflux pre-op, nearly 2/3 are still using medications between 1 year and 5 years after surgery, and that reflux can worsen after surgery in sleeve gastrectomy, in Roux gastric bypass, and of course after gastric bending. However, some reports indicate that there is still good control of the reflux after Roux gastric bypass on medium term. What about treatment of failed anti-reflux procedures? The picture is not very clear because in a series of conversion of anti-reflux procedure to Roux gastric bypass, there was significantly more complications after conversion into gastric bypass compared to redo anti-reflux procedure, and the effect on the reflux seemed similar, although patients lost more weight, of course, after Roux gastric bypass. And the problem seems that reflux is usually associated with the presence of hiatal hernia, and that even after Roux gastric bypass, this is probably the reason for the recurrence of or maintenance of the reflux. What to do with the sleeve gastrectomy, which leads to intolerable gastroesophageal reflux. There is an incidence of 1.8 to 8.9% of conversion of sleeve gastrectomy for gastroesophageal reflux itself. And the remission of or improvement can be obtained in 66 to 1% of the cases, with a very variable follow-up, as you can see. And repeat sleeve can also bring some improvement, as you see in this report. But most of the time, gastroesophageal reflux can remain incomplete. And again, hiatal hernia in recent publications seem to play a role in the recurrence of the reflux. And as you can see here, when the hiatal hernia is present, there is a higher prevalence of esophagitis compared to when the hiatal hernia is not present, whatever the sleeve or even the Roux gastric bypass. So in conclusion, although not perfect, Roux gastric bypass remains the best option for obese patients with gastroesophageal reflux, or when converting a sleeve for reflux versus re-sleeve. We don't really know the mechanisms through which Roux gastric bypass is effective, but probably because the acid within the pouch is quite reduced. Hiatal hernia is probably a critical repair, and repair should be done, whatever the procedure, sleeve or even Roux gastric bypass. And in case of reflux, because the symptoms are quite subjective and not necessarily related to the presence of esophagitis or objective reflux, objective testing should be recommended. Thank you for your attention.
Bir soru salondan alalım. Buyurun lütfen.
Evet.
Sayın Topart, çok teşekkür ederiz güzel sunumunuz için. Ben şeyi sormak istiyorum. Şimdi gastroözofajal reflü obezlerin genel sorunu, yaklaşık kendisi %30 verdi ama bizim bildiğimiz rakamlar %40'lara kadar çıkıyor. Ancak obezite cerrahisi başlı başına reflüyü düzelten de bir faktör. Yani hangi sleeve de yapsanız hastaların bir kısmı ya rezolüsyona uğruyor ya da improve ediyorlar. Yani bu da yaklaşık %30-40 civarında. Elinizde böyle bir rakam var mı? Yani mesela hastaya sleeve önerip, slaytınızda da zaten ilk paragrafta sleeve'den sonra Roux bypass yapılabileceğini ifade ediyorsunuz. Sleeve'den sonra veyahut da obezite cerrahisinden sonra hastaların yüzde kaçı tamamen improve oluyorlar? Ve kalanlar için yüzde kaç oranında bypass gerçekleştirdiniz kendi serinizde? Yani bu önerinizi yaptığınızdaki yüzdeleriniz nedir?
Thank you for your question. Actually, if the patient, after sleeve, you meant, if the patient has a reflux, about 40% have reflux after sleeve. If they are controlled by the medication, I don't do anything. I just reoperate and just convert to Roux and Roux gastric bypass those patients who are uncontrolled by the anti-acid medication, and after objective testing, because we know that after conversion to Roux gastric bypass, there is about 75% of the patients who will have remission or improvement. And I always warn them that even after conversion to Roux gastric bypass, they may still need medication, but will be improved in 75 of the cases. So I try to reoperate on only patients with a very objective proof of the reflux. Otherwise, results might be less enthusiastic. And I try to repair hyperthyroidism, whatever.
Can you give any figure about this group of patients that needs to... bu grup hasta için rakam verebilir misiniz? Yani medication'a ihtiyaç duyanlar dışında ameliyat ihtiyacı gösterenlerin yüzdesi ne kadar?
As a whole, about 5% of the sleeves we do, and it's the same in the groups, will eventually require conversion to Roux gastric bypass for uncontrolled
Teşekkür ederim.
effects.
Teşekkür ederim.
It's a minority.
Doktor Philippe, teşekkür ederiz. Bu geniş bir konuydu. Bize toparladınız. Ben de küçük bir şey sormak istiyorum size. De novo, yeni görülen reflü açısından baktığımızda sleeve tekniği için konuşuyorum. Antrumun korunması konusu pilordan mesafeyle de novo yeni reflü ortaya çıkma ya da reflünün kötüleşmesi arasında ilişki açısından ne düşünüyorsunuz? Yani pilor stapler başlama mesafesiyle reflünün kötüleşmesi, remisyon olmaması ve yeni çıkması arasında ilişki hakkında bir tecrübenizi öğrenebilir miyim?
I don't really have a clear idea of the way which is make a sleeve can promote reflux or not. Actually, I'm quite confused. And to speak frankly, I don't like the sleeve very much, and I try to do as many Roux gastric bypasses as possible. But I'm not sure. I'm not sure any technical aspect of the sleeve can improve the reflux or not. It's a very reflux-prone procedure anyway. Not a bad one, but very, very reflux-prone procedure.
Peki başka soru olan var mı? Alandan diyorum. Teşekkür ederiz.